Good evening, everybody. It is Mark from Modern Pain Care. Sorry, here my shirt's unbuttoned. I apologize for that. Good evening. It's about 7 o'clock here in Phoenix, Arizona, and I'm excited to come to you guys tonight. We have our second batch of content that we'll be bringing to you guys. We got 4 weeks of content. I'm excited to share all the stuff we got with you. Jared's produced a bunch of lectures. We're going to probably have our buddy Marcos Lopez bring out some stuff. We'll be interviewing Jason Silvernail this weekend on Saturday. So if you guys have any questions, make sure you check the thread out in this group, because you can ask Jason anything. Jason's been kind to say, whatever you guys got for me, bring it. So if you guys have any questions for Jason, anything that you're thinking about from maybe pain science, Jason's a wealth of information, probably one of the bigger influencers in my clinical thinking and critical thinking skills, just from interacting with him online, and fortunate enough to interact with him a little bit in person at the San Diego Pain Summit. But a great opportunity this Saturday at 10 a.m. Eastern Time to talk with Jason. So, and that's just the beginning. We got a bunch of great content coming for the next few weeks, and then we're going to have our big training here in December on the 11th, where we're going to really announce our big program that Jared and Marcos and myself and others that have so many awesome bonuses and stuff that I can't wait to share with you guys. But that'll wait till December. But for right now, let's share some good stuff that's going to hopefully help you guys help more people in the clinic. So tonight, what I wanted to talk about is the therapeutic ritual. And therapeutic ritual, we all have them. We all perform rituals with our patients. I mean, I don't think we think of it that way traditionally, but the whole act of, laying your hands on a patient or going through a ritual of, maybe you're more of an exercise-based therapist or whatever it may be, but it's a ritual. The patient's coming to you for technically healing. So it exists in all of our practices, and it's something we should be aware of. I think if this is something we can really maximize, I don't think we often consider that this is a big part of, this whole placebo or non-specific or meaning response. This ritual is what creates the meaning for the patient, and certain patients ascribe different meanings to different rituals, and they'll seek different rituals for their healing. So it's a very important thing to consider and to look beyond just what we speculate, maybe the isolated specific effects of an intervention, because interventions don't exist in a vacuum. They exist in a context, in an environment, in a place where hopefully if you're a science-based practitioner, you're trying to understand that context and try to create a context that's set up to the best of your ability to really maximize your outcomes with your patients. So if you look at the picture of this gentleman on this film, like for me, that's a guy, if I walk into a treatment room and that's what's staring me back in the eye, I'm going to probably walk the other way. That's just not my cup of tea. It's not my thing. But in some cultures and in some societies, that might represent somebody who has some serious healing mojo behind them. So I think we have to recognize that different cultures ascribe different things to healing. So and the whole evolution of the doctor-patient relationship, and if you read of anything of Fabrizio Benedetti's work, he's really looked into this doctor-patient relationship and some of the physiology of it. And really, over time, we've evolved from shamanistic medicine, where it was very religious and supernatural, to just the modern shaman, which is the physician or the healer, which could be a chiropractor or a physical therapist or a physician or whatever it may be. But in the end, human beings have evolved to seek a healer. That's just the way human beings are. When we are faced with a situation, maybe it's a pain situation, maybe it's something where it exceeds our current coping strategies or our current abilities to deal with it, we seek outside help. And that's where I think sometimes we have to be careful to say, well, everybody should have self-efficacy. Everybody should be able to just leverage their own healing and take it on and not need external help. In a perfect world, I guess maybe that would be the case, but that's not how humans are wired. We're wired to seek help. Now, hopefully, when people seek our help, we have a narrative that's founded in science and founded in evidence and founded in a movement towards that patient's self-efficacy, where we're hopefully moving them to control their own symptoms, to where they do have the coping strategies now to take their symptoms on and manage their condition without the need of us. I know for me personally, when I've really started to look into, when I first started getting into all this technical training and manual therapy and in exercise and different things, and even in physio school, I really only thought of this linear pathway of, okay, I have a treatment, there's specific effects behind that treatment, and I get a clinical improvement. And I didn't really consider anything external to that in my practice. It was always going to be specific to what I did in that treatment, how well I locked out the facet from 4 different planes of movement. I joke, of course, or how well I really isolated the movement to one spot. Things that traditionally I think we're recognizing probably not necessarily as important as what we thought it was, and maybe it wasn't that part of the technique that really drove the outcome. So to really look at the whole picture of an outcome, and this again comes from Benedetti's work, we have to look at a lot of different things that can influence clinical improvement that's in front of you. I think we all probably have a little bit of a bias to kind of ascribe improvement and healing to ourselves and what we do, and I think that's something where I've really moved as I've gotten into pain science and read into this stuff to really give the patient's body credit, give their abilities to heal credit. And I think that was a move for me that I think my clinical ego initially in my career, where I wanted to have all these letters and I wanted to have all this status as an amazing manual therapist who could just, put my hands upon somebody and heal them, where I think, again, I stole the patient's self-efficacy with that model of thinking a lot of times in my career, to where now looking at other things that influence the patient's outcome. Of course, our techniques are important and different things, to an extent to help a patient move forward, but maybe it's not techniques, maybe it's a lot of the other things surrounding it, like natural history. Patients that come into us that are injured, the natural healing and history of a condition usually works in our favor. They're going to move hopefully in a positive direction, provided there's not other comorbidities or complicating factors that might be preventing them from healing. Regression to the mean usually is when a patient hits you at a high level of symptoms. They're at a kind of an extreme. Their symptoms usually have only one place to go. They only have a place to usually go back to the mean or to the lower end. Co-interventions, we don't know if along with their treatment with you, they've been just really resting and letting healing happen, or maybe they had a really good discussion with or breakthrough with a nasty relationship with their employer. Who knows what it may be, but I think we have to be mindful that there might be other things going on in the patient's life that could be bringing some degree of improvement as well. The patient's biases, as much as we want to think that patients all have biases that are science-based and evidence-based, we know that's not the case. And you watch late-night TV and you see patients who are biased towards these crazy interventions, who are on TV throwing testimony after testimony about these interventions that make no sense whatsoever, yet that's the patient's bias. And that patient's bias and belief is a powerful modulator and a physiological modulator of their response to treatment. So I think we have to be mindful that that bias is important, and we should understand it and ask about it. What do you think is going to help you improve? What do you think you need to improve? What kind of things have you found from a physical therapy or chiropractic standpoint or massage standpoint have really brought you improvement in the past? And that's where we start to understand that patient's biases, and ideally we can maybe meet that expectation or bias, provided it's not so off the map that we're going to be just furtherly taking the patient's self-efficacy away from them. But it's definitely something we should understand. Clinician biases, we're going to show you some studies that show how important it is to understand our own biases and how they affect some of the results we see in clinic. And then psychobiologic factors is really a lot of what we speak about when we talk about nocebo, placebo, and all these things, as far as just some of the perceptions and meaning that our patients ascribe to treatment or an intervention, and how whether it thinks of a positive response to it or it generates a positive expectation, it can unlock different biologic pathways, which we'll talk about in a second, or negative expectations can unlock different neurophysiological or neurobiological processes in a patient's body, all through kind of expectations. And again, understanding those things is crucial. This is a great study that I took from Lorimer Mosley's, one of his lectures, and I think it's a great study by Gracely et al., and I think it was 1985, but it was basically some folks that had their wisdom teeth taken out, and they took split this group of people into two groups, and they had these two clinicians who, the clinicians were in two groups, and the clinicians were, one clinician was delivering a fentanyl, noxolone, or placebo injection. So the physician or dentist, I believe, necessarily didn't know which they were blinded to which one, but they knew in their group that some of their patients were going to be getting fentanyl, which is an active pain reliever. The noxolone and the placebo don't have any pain-relieving qualities as far as shouldn't have any active ingredients to relieve pain. And then the other group had a dentist who was delivering placebo or noxolone. So this one group, one dentist knew, hey, some of these people are going to be getting the real deal, the real pain-relieving thing, and the other dentist thought, I'm only giving placebo or non-pain relieving thing. So this clinician's expectations were significantly different in these studies. So what happened? Well, they looked at what do the placebo groups look like, because in the placebo groups, they're both the dentists are both delivering placebos, so they're exact identical treatment. So ideally, if there's no influence on the clinician, it should be the same response. But what they found was the placebo group that was given by the dentist, who also knew that some of his people were going to be getting fentanyl, is the bottom dotted line here, where they showed these pain ratings actually decreased, where this dentist, obviously there were some non-specific effects or treatment interventions or something, because again, these are the same exact injections, but when a dentist who doesn't think there's anything good and positive happening, these patients actually had pain increases. When there's a dentist who thinks that, hey, some of you guys are going to be getting the real deal, and there's an interaction that changes or some sort of treatment of, kind of non-specific treatment effect or interaction effect, then all of a sudden these patients are getting a decrease from the same exact injection. Only difference was the dentist's belief that, hey, some people in this group are going to get the real deal. The dentists in this group didn't have that expectation or belief. And that's something important, is just to understand that how we believe in an intervention affects outcomes. And here's a great study from Chad Cook that looked at thrust versus non-thrust. That's always a big debate in the manual therapy world. You need to be cracking and popping, or no, you need to be mobilizing, and there's, camps that get all grumpy at each other over which one's better than the other. Regardless, this study showed that there wasn't really any significant differences in mobilization versus manipulation in this group, but they did show that the biggest thing that affected outcomes was that therapist's personal equipoise, and that's just like their belief in the intervention. So if I was a clinician in this study and I believed in mobilization, then I tended to get better outcomes with mobilization. If I was a clinician who believed more in manipulation, then I tended to get better outcomes with manipulation. So it's just to show that, and again, think about some of the studies that we see out there. We get like folks who are like manipulation specialists, maybe chiropractors, and then they compare it to a McKenzie thing, which they're not trained in maybe, or maybe they just don't have the same expectations or beliefs in it. So again, there's going to be significant interaction effects and different things, which I think we have to really look back at studies. When we have people studying things that they have a vested belief or interest in, especially if they're teaching it for continued education money, I think we need to be mindful that, gosh, there's definitely a lack of equipoise as far as that clinician is going into that study significantly biased, and you got to imagine they're interacting with the patients in those studies differently. I mean, if it's like, somebody at McDonald's who's, comparing hamburgers to salads, and, McDonald's doesn't necessarily want to sell salads, so they really pump up the burger to these patients, and then, well, here's your salad. And so again, you're almost creating an outright, bias towards that patient to positively respond to the hamburger in that situation. But I just think that's just one example, probably a bad one, and I apologize. But we have to understand that our studies are riddled with a lack of control of this, and that's where I think Chad Cook has really made some suggestions in his discussions around equipoise, that we need expert controlled studies where if you're going to compare mobilization versus manipulation, then get experts in each and have them both deliver the intervention arms of those studies, not experts in manipulation delivering a manipulation arm and then experts in manipulation then delivering a mobilization arm in a study. I think that would help control for some of those things. Daniel Mormon is somebody who's, I believe, an anthropologist. He's retired, a Facebook friend, believe it or not, but from the University of Michigan, no longer, I believe, currently in faculty there and doing active research, but termed this whole placebo response a meaning response. And so really it's made up of the words that surround an intervention, the rituals that surround an intervention, the symbolic elements that, and you can think about it, some of the symbolic evidence of the treatment table, the manipulative positioning, the manual therapy examination where we identify some specific fault or problem in the spine and we we go through these words, and hopefully we don't tell people things are out of place or things are unstable or whatever things, but these words and things have meaning for people. Folks that believe the subluxation narrative, the words of here's a subluxation, this is out of place, this ritual of looking at alignment and putting them in different things. We know there's not a lot of science to support this, of course, but this ritual of looking at specific alignment things, identifying, which always usually happens to be around where they have pain. There's some alignment issue, of course, because of our biases, and then we go into this ritualistic manipulative procedure and supposedly put things back into alignment. We know that's not what happens, but patients believe that happens, and I would argue that the belief of that around the manipulation is a huge component of the outcome, and we'll show you when we take the ritual out of manipulation, it isn't nearly as effective. But it's all about the context that surrounds your treatment. So you should know what the context is around your treatments. You should try to develop words and explanations and different things around your treatments that maximize the context, that maximize your response to treatments, instead of just kind of blindly throwing treatments without any control of those things. Why don't you have a clear understanding of everything from how good your front desk person answers the phone and is kind and welcoming to your patient, how well they kind of don't enforce negative pain behaviors, and how well they don't do different things, how well your treatment room's set up. If you have a persistent pain patient with migraines, they probably aren't going to do well in a loud gym setting where you got freaking loud rock music playing in there. So you just have to understand your context and recognize that some certain contexts may work better for certain patients. Yeah, so we got Will Boyd and Amy on here. Good to see you guys. So really, when we have, and if we look at this, traditional physical therapy, chiropractic, and other professions, our reasoning is stuck here in the tissues. And it's not bad, because tissues get strained, we sprain, we herniate discs, we break bones. So there are definitely times where tissues need to be looked at, and we should never forget that tissues are an important part of the equation. I think one of the straw man arguments that gets thrown against folks that are supposedly in the pain science crowd is that all of a sudden we're just talking to people and we're no longer examining tissues, and we're no longer being good orthopedic therapists who are screening for red flags and doing movement assessments and different things, which couldn't be farther from the truth. But so anyway, tissues are one output, or input I should say, and then we have the environment. We have the smell, the sights, the sounds, and different things that we create in our clinical things. We have the interactions with staff and other patients, word used by clinicians, staff, and patients, and unfortunately Google, which we know can be a dead end of nocebo for a lot of patients. That person's personal beliefs and expectations, the therapist variables, how does the therapist look and how are they interacting. As much as we don't like it, some people, I don't mind it actually, but some people are very much more going to look at people who are well dressed, and maybe a shirt and a tie, or more of a casual, as more professional or more useful clinicians, whether we like it or not. Memories from past therapies, that's another thing we should be thinking of and asking about patients. What have you had that's been successful for you in the past? Of course, we have to be mindful of what the narrative is around those interventions and maybe try to steer it in a more adaptive view. But these are all things that are going into the brain and the nervous system, again, including nociceptive input from tissues. It doesn't mean that doesn't exist. And then the nervous system has to make, what does this all mean? With all these things that I take into account, what does this all mean? And that determines what kind of inputs go towards tissue. Does the tissue get less sensitive as you're doing that manual therapy technique? Because they have a background of great response to manual therapy. Manual therapy to them signifies healing. It's a ritual they believe in. That's something your clinic delivers. It's the culture you create, which is fine. Just recognize that that's part of the gig when you create a manual therapy setting. It's what I create, and I'm okay with it, but I recognize that that's probably a big part of my outcome as well. Outputs also, though, are not just our immune system, our endocrine system, autonomic system, behaviors, many more systems involved in just that. But the problem is we automatically think it's just our linear intervention that affects these things, and we see all these studies now that are looking at immune system markers and endocrine system markers and all these things, like it's our unique intervention that changes these things. Anything that can ascribe healing and a positive response to a patient, a placebo response, which isn't a bad thing, could change these symptoms irregardless of how effective or ineffective that intervention is on its own from a mechanistic perspective. So that's where I think we have to be careful, and we'll talk about that here a little bit more. But this just shows that this whole negative context, positive context, there's neurobiology behind this. I'm not going to go into all these different pathways and different things, but positive context tends to rely on our opioid system, our endocannabinoid system, our dopamine, oxytocin, vasopressin systems. Negative context goes into other different things, our lack of reward, different things with our dopamine, our opioid deactivation, pro-inflammatory things. So these contexts and our ascribing of negative meaning or positive meaning has neurobiological differences that you better believe can come down from the spinal brain into the spinal cord into that target tissue and modulate the degree of sensitivity to this. So it could make your description of what grade mobilization and how sensitive that tissue is before your pain versus resistant relationship and change it more from a top-down perspective. So we have to understand that the top-down influence on what we're feeling at the periphery, it's important, and that's why, again, you need to understand everything that surrounds your intervention. Our clinical reasoning needs to expand hugely if we're going to really be the practitioners that are the frontline musculoskeletal practitioners that we'd like to be. So when we think of a meaning response or placebo response, the principal elements of the patient is trust, which is mediated through the amygdala and through oxytocin. I'm not going to go again through all these pathways. The admiration for virtue and skill. And if you look at some of the gurus out there or some of these high-level elder, like guru manutherapists, they have extremely skillful, look at it and think about it. Let me just assess this for the therapeutic ritual. And you'll see that these gurus are amazing at just that interaction, that just grabbing that interaction, being able to just sell that patient to, they're just drooling for that guru to put their hands on them and deliver this intervention. Sometimes, and I've worked with a lot of high-level clinicians who are very aware of this, that their reputation and this thought that, I'm going to refer you to see, Captain Guru physical therapist across town. He's the most amazing. He treats all the pro athletes or all the high-level, blah blah blahs in the city. Oh, and you're going to be able to see him. I mean, that cues this up to this patient's expectations are just brimming. And I always do that when I refer a patient to another clinician. I cue them up for success. I say, you're going to see an amazing clinician who is so skilled in pelvic health, because I don't see pelvic health, that they're going to be able to really look, do a detailed examination, and really be able to help you in ways that I can't help you. So I'm excited for you to go to see them, because I really think they're going to do some amazing things with you. So cue your people up, cue your tribe up, your fellow teammates up, because that actually can help their outcomes when you set them up for success versus, well, you're going to see this person, they're going to probably be late, or they're not the best, or they're not the best people person. Hopefully nobody's doing that, but we should be aware of that virtue and skill, and cueing the patient to expect that virtue and skill can help that outcome when that patient then gets in front of that next clinician. Hope and hopelessness. Jared's going to share a lecture on learned hopelessness, which is a huge issue that I think some people just have given up the idea that there's any ability to change their pain, and that's just a miserable situation that way too many people are in that shouldn't be there because they've traveled on the biomedical merry-go-round of disability, but that's mediated by serotonin, noradrenergic systems and mechanisms. And then I'm not going to get into the detailed nitty-gritty neurobiology of this, and I'm not going to lie to tell you that I'm an expert in that neurobiology, but I just want you to understand that these thoughts, beliefs, and things that are cognitive, psychobiologic things affect your biology. These chemicals, when they start permeating through the body, can definitively affect how sensitive your tissues are and how well you may move, how well they may respond to an intervention. So the hopelessness is real. I know you've been there, Miss Amy. So, and we're going to talk to Amy in a week or so about her experience, and I definitely want to hear your perspective on that from your experience with your unique pain journey. So, looking forward to it. The role of personality. This probably doesn't come as a surprise to any of you guys who are listening here, but Gears and his colleagues in 2007 shockingly found that pessimists are more prone than optimists to follow a negative expectation or a nocebo expectation, and optimists have been shown to have a positive relationship to placebo responding. And we probably see that. We have the patient who, it's almost got that Eeyore personality from Pooh, where, oh yeah, it's terrible. They just have this negative expectation and negative outlook. And those are the folks with depression on board and different things that I would argue they need to find some meaning and some value and something to get them out of bed and excited. It often needs to be from a psychology perspective or a behavioral mental health professional to help get that person out of depression, because it's hard for people to have positive responses to anything when they're in the dark caves of despair that can surround them when they're dealing with a pretty complex pain journey. The meaning of symptoms. Cancer pain is perceived as more unpleasant than post-operative pain. Again, that shouldn't be a shock. One means possible death. The other means, hey, I just had an operation. That's a healing procedure. Religions can ascribe different meanings to pain. It's God's will. It's different things where I think that can be a helpful coping strategy for folks that are religious. Changing meaning from pain to negative to positive, it taps into that opioid cannabinoid system. I can never say that word. I think I did it okay there. But it's, again, just to know that when we start shifting these things, there are neurochemical events happening in your brain that are shifting different pathways and different systems to start activating and producing some pretty potent, powerful pain-relieving stuff in the patient's body. There's a book, I believe, by Ian Harris that talks about surgery, the ultimate placebo. I think it's Ian Harris, I could be wrong, but surgery is probably the biggest therapeutic ritual, at least in American society. That is the ritual of healing that I think all of our patients, I know how many of you guys on here have patients that just look at surgery like it is the magical fix-all, cure-all. I've had patients that I swear are like professional operative patients where they're like, it's like a badge of honor that they're going for their next surgery to get cured and rid of some, proposed pathoanatomy that's the scourge of their life. But I think we've all been there. And so there's a huge therapeutic ritual, the whole physician's interactions before the surgery, the checking in the hospital, the donning of a gown, the getting on a gurney, all these things, and all those things that surround these interventions that are extremely powerful. And again, the meanings we ascribe, we have all these, our culture that just celebrates the physician, and they should be. Surgeons and folks that do that are amazing. They do some amazing healing things. I'm not saying we shouldn't be, but it does create this like almost God complex with surgeons that they're going to go in and cure the world of all these ills. And we know that surgery, which we'll talk about here in a second, has its limitations. But then that therapeutic ritual becomes important when we hide, surgeries, or we don't do the surgeries, which we'll show you here in a second, where we kind of make the patient believe there was a surgery when it wasn't, or we hide the administration of an opioid where the patient doesn't know they're getting pain relievers. They don't have that nice thumb depressor that signifies pain relief, that is accompanied by a beep and a plunger depressing in their little PCA pump. There's a lot of study that went into those PCA pumps. There's a reason the patient has to depress it. They can see it, and there's sounds on it. I'm sure there's been plenty of research for the vendors of those machines to maximize the pain relief that comes out of their PCA pump. So we have to understand that there's a massive amount of ritual and placebo responding that happens in surgery. And when we look at these studies of placebo surgery, I remember talking to Adrian about this study and how nobody wanted to touch this study with a 10-foot pole, because it really threatened mainstream medicine, which is a very, you threaten the surgical industry and you're going up against a lot of, money and lobbying power, and, it's a pretty dangerous thing to do. But this looked at a systematic review of sham surgery. And when we looked at procedures such as radiofrequency lesioning, arthroscopic debridement, and lavage of joints, vertebroplasties, I honestly can't remember what inertial debridement is, and an IDET procedure is, I believe, is some sort of thermal procedure in the spine, that these sham procedures did very well to the real surgery. So if we could but I honestly think that the surgical industry has gotten so far past the evidence horse. I always joke that surgical cart is so far in front of the evidence horse that it's almost beyond repair. But as far as and who's going to write a study, and what's going to pass an IRB where you can do sham surgeries here in the U.S. or do a fake surgery, or I'm going to take 100 of you guys, 50 of you, I'm going to tell you're getting surgery, but you're really not going to. I think there's, for obvious reasons, there's major moral and ethical issues there, but it's something that would be interesting to see if it was a possibility to see how much is truly due to belief and that they've been healed. And we have folks that we talk to regularly who have stories about their surgical procedures and different things. And I think, Amy, you'll have a story about your surgical procedure and different things and your experience with that I'm not saying your surgery was a sham, of course, but you've mentioned some stories to me that I'll look forward to hearing you share with the group. And again, this kind of goes a little bit with social learning, because we've socially learned culturally that surgery is some healing ritual, that we should respond to this. And, media and infomercials, I've spoke about it already, but, late night TV is so full of infomercials. And I'm sure there's market research to understand that the folks that are in chronic pain, who aren't sleeping, who are desperately watching TV to pass the time because they're in, pain, that's when these infomercials come on, and that's where people, I'm sure they probably studied and seen where they sold the most of their product. And there's a reason that those folks are on TV at 2, 3 in the morning. But, it can be as powerful as experiencing it themselves. When you see friends who, man, my friend went in and got this manipulation, and they went from bent over and couldn't walk to healed. Oh my God. And it's almost like that. Your response to that intervention is already queued up, ready, because you've just seen something amazing happen. And there's been studies of that, I don't have them all here, of social learning and that different things. But we are born into a belief and behavior system within our culture of wherever we live ethnically, but also within our family, within our workplace, within our peer groups, that shapes our beliefs and behaviors around pain and shapes our responses to different interventions. So that's important things to understand around our patients. Expectations, that doesn't really surprise anybody, but when we think about predictive processing, these social learned things and things form those prior expectations, that running set of sensory expectation of what we expect to happen, and our priors that are produced. So predictive processing and expectations are really one and the same. Our priors are what are our expectations, whatever we've experienced in past experiences, the meaning we've been taught of certain things really cues up our body to, have a physiological response to that expectation. Decreased effectiveness of hidden treatments, I've alluded to it already, but when you don't create the expectation, we don't necessarily have that ability to have the outcome. The ritual's not there. When people don't see the ritual of the needle going into the IV line and delivering the pain medication, and the doctor saying this is going to really decrease your pain or whatever things, when you lose the ritual, you lose a lot of effectiveness of that. And I always joke, would a robot be able to just come into this sterile room with just you and a treatment table and position you, deliver manipulation, no communication, and then come out? Now, if you're a huge fan of robots, or you think robots are the most amazing thing on the planet Earth or ever, and oh my God, that was the most amazing thing, then you might have an amazing response to that. But I would argue for manual therapy, it takes that interaction and that context that you create and that expectation that you create and your explanation and how well you handle and position the patient and how well your nervous system's interacting with theirs through touch and different things that are important parts of it that we need to recognize and think about when we're delivering that. And when we do studies that take the ritual out of manual therapy and manipulation under anesthetic, the patient's under anesthesia, and the patients go to get manipulated, and lo and behold, there's no significant difference in that. When we looked at Gordon, Cremata, and Hawk in 2014, and Diogeo in 2013 looked at that and saw no significant improvements with manipulation, no support for that treatment for chronic low back pain. So again, ritual, hugely important. We should understand it, we should leverage it, and know what's going on. The rituals that are on cupping and different things, but this is more on placebo. But athletes are probably one of the massive placebo responders. I have huge respect for sports PTs because they deal with athletes who are so quick to jump on the latest fad and the latest thing that's going to give them that little sliver of an edge that could be the difference between a scholarship to a D1 school, or maybe they're going to make it into the pros or different things. Where I do know there's sports PTs who say they almost have to deliver some of the foo-foo, voodoo stuff, and then really to allow them to get into the real deal stuff that's going to actually get the patient better. But they've done placebo drinks for cyclists and showing significant improvement in performance. They've done it with weightlifters. They did a placebo steroid and saw significant improvements in strength tasks. So there's physiologic stuff that happens with expectation, and I think we just got to be mindful of that within our clinical practices. I'm going to leave you with this slide, and it kind of goes back to what I talked about how we can condition our immune and endocrine responses from past responses and past meanings and things to when we have ascribed and defined some ritual as healing and an amazing thing, that we almost condition our immune system, our endocrine system, to go into a homeostatic back to safety mode. And that's just where we have to recognize that that exists around interventions, and for us to just cordon off these little immune system studies and endocrine system and look at these chemical markers and say that's all my intervention that's doing that. I think any intervention that's popular with the patient, that's been marketed heavily to a patient, that the patient has got a drooling belief in that your clinic, has marketed and has a culture around, and I have a culture around manual therapy, and I will definitely say I probably affect immune responses and endocrine responses by delivering expectations around manual therapy interventions. It's not definitely the hallmark of my practice, but there are patients that come in with that expectation and can be part of an evidence-based part of care, unless you're talking Adam Meekins, of course. Joking with you, buddy. Hope you're watching. But anyway, it's just important to know that we can't lose sight of what pairs up with our interventions, and we can't give our interventions all the credit. Give the patient credit, and that's a hard thing that was for me to do, unfortunately, when my clinical ego was so high and I was this guru or wanting to be guru manual therapist who was going to heal the world. It truly was a limiting thing for me. So with that said, I am going to wrap up for tonight. I really hope you guys enjoyed the talk. I'd love to hear your questions and things that may have struck you with today's talk. What do you guys think about the therapeutic rituals in your practice? What do you think are things we should be doing or maybe not doing around therapeutic rituals? Is placebo a bad thing? I think it gets labeled as a bad thing, but I don't really. I mean, it's a part of everything we do. There's non-specific contextual meaning responses that patients are going to be ascribing to what you're doing to them. So let's understand them. Let's do our best to leverage them in our practice in an ethical and moral way. And let's help more people.